patients can also have this accessible at the center. We'll also look at how the NCAP can also be accessible by indigent patients from that area. And what are your plans for those who are unaware? Again, because of the elections last Saturday, we were supposed to have our first awareness campaign in Kano State to create awareness and also screen patients free for breast cancer to mark the Pink October. Definitely activities around awareness will be part of our day-to-day activities in the center to create awareness for people around the environment. So we are rescheduling because we had to postpone it because of the local government elections that was held last Saturday in Kano State. Yes. Yes, we have the 4D ultrasound to check our applicators if they are in place. I couldn't put it on the slides, but we have all that we need for brachy. Yeah. And then yes, simulation through CT.
Thank you very much.
All right, thank you. The first question, if we consider catheterization in the patients that were recruited into the study, no, we did not do that. So that can also lead to the presence of microorganisms in the urine, but we're saying that if we had more study sample, a larger study sample, then we can get a good picture of all the microorganisms that are present in the urinary tract of men with prostate cancer. That also goes to the question that was asked about if the isolates that we got, the microorganisms were from prostate cancer or from secondary infection. Some may actually have secondary infection, but like I mentioned, we have a larger study sample, we can actually take care of that. Now, that question was if we consider the microbiome of other body sites. In this study, apart from the urinary microbiome, we also considered the gut microbiome, which was also sequenced, but I didn't make any report on that. So we can actually use sequencing techniques to carry out microbiome studies. That also prevents contamination because you are only sequencing the reserved or conserved regions in the 16S RNA, and then you have a good picture of all the microorganisms that are present in different sites of the body. The first question that was directed at me was on the functional metabolic pathway that we talked about. All right, so we found that arginine biosynthesis pathway was increased in cases while vitamin B and K was increased in control. This only shows that if we reduce arginine for persons that have been treated for prostate cancer, we can have a better outcome. And then if we give persons that have prostate cancer vitamin B and K, we can also have a better outcome. Thank you.
Thank you very much. You have about 3 questions here. 4, so be very brief.
All right. So the first question was about the demographic stratification of the control group. So the control group samples were actually gotten after free screening, and these people were found to not have prostate cancer. So there were people that fall between the age of 45 to 75 years of men that consented for the research and do not have prostate cancer. Then the second question that I was asked was, why did I not include prostate cancer, like those that for my cases before they started treatment? So because I got ethical approval, it has to be people that already have cancer. And if I say I only want to pick samples of people that are yet to start treatment, I may not have up to 40 samples because it's even difficult to gather samples. So that's why there were people that were certified to have prostate cancer. And from the clinical parameters that I got, these people were already undergoing anti-androgen treatment. The third question that I was asked is if these studies, the genes, why I had to study the gene. So these genes have actually been implicated in several studies, because if you look at the androgen receptor pathway, the CYP17A1 is a key driver and a rate-limiting step in that pathway. And studies have also found that testosterone actually drive prostate cancer. So most of the anti-androgens actually target CYP17A1, which is actually cytochrome P450, which is a drug target, for example, abiraterone. But for the HSD3B1, studies are still ongoing to find biomarkers or possible targets for it. So these studies have actually been implicated, the genes have implicated in other studies. Then the fourth question was about the testosterone, high testosterone level. So from my studies, we just did T-test to check the main values for the levels of testosterone, and we found out that the controls, that their testosterone level were higher than the cases. And I mentioned that this is as a result of those that we have under cases, they were already undergoing anti-androgens. And what do anti-androgens do? They reduce the levels of testosterone. So yes, for the last question about if why no treatment we are giving to the control group. Of course, there's no treatment, they don't have cancer, so we cannot give any treatment to them. Okay, so some of them were no, I didn't get all those data from them.
It's okay. I think it's not that the testosterone is high, but it's your confounding issue that they are on treatment. So that's why people are saying, why should the normal be high? Is that not correct? Is it outside the normal range? Is the normal control serum testosterone outside the normal range?
So the thing is this, so let me reiterate this, is actually because this is the case control study, so I'm comparing with the cases. So in the cases,
it's higher than this, but not like
yes,
higher.
Yes, that's the thing, yes,
Okay.
yes.
Okay. So next topic, please make sure you take your serum testosterone before treatment starts, if possible. Otherwise, this is a limitation which you must highlight. Good. Last speaker.
Thank you. The first question is cause of transient erectile dysfunction in our patient. The causes of transient erectile dysfunction in our patients is multifactorial. The first one is psychological. These are patients who had major surgery. So during the recuperation period, they expect them to have some psychological impact on the erectile function. But most importantly, the organic components. The nerves that are controlling the erection actually are periprostatic, within the planes around the prostate. So when you are trying to remove the prostate, there is some dissection that could be around this nerve. And remember, the cohort of our patients in this study are locally advanced. Some of them, which means that the tumors are actually locally exceeded the capsule. So during that dissection, there's a risk of damage to those nerves, and that's why erectile dysfunction is an issue in this group of patients. But the treatment for such patients is that usually we commence them on upfront phosphodiesterase inhibitors, since we know that they are at risk of this complication, as well as some of the precursors of nitrogen oxide like L-arginine. So this helps to improve the erectile function after surgery. The second question is adjuvant radiotherapy as a multimodal. Yes, part of the protocol of this study is that for those patients who have positive margins or positive lymph nodes benefited from adjuvant radiation therapy. In our patients, 3 out of those patients actually have positive lymph nodes, and they benefited from those radiation as well as the long-term androgen deprivation therapy. Thank you very much.
Let's put our hands together for them once. And if you don't want to offend me, please clap for my big tummy. And we have photographs. So let's have co-chairperson come, please.
Well, just to recognize the fact that we have quite a number from Covenant University. I think a round of applause for them. They don't have teaching hospital. They don't have teaching hospital, but you'll be seeing Covenant University, Covenant University, Covenant University. So I think you guys are doing well. Thank you very much.
And again, we must commend the diversity of the speakers. Give us this. A woman between the men, okay? Right? And then come in next to me here. You can see the surgeons are there. And then are you a surgeon? This is a urologist, cancer researcher, oncologist, medical microbiologist, a pharmacist, public physician, a psychologist, and a farmer. Thank you.
Please, can we put our hands together for this session? That was the fourth oral abstract presentation chaired by Professor Sunday A. Adewi of the famous Ahmadu Bello University Teaching Hospital Zaria. It was co-chaired by Dr. Tesi Amadu from the Federal Medical Center, Jabi, here in Abuja. The next is going to be the fifth oral abstract presentation, which is to be chaired by Professor Rose Anolu from the Lagos University Teaching Hospital, as well as Professor T. Olasinde, who is going to co-chair the session from Ahmadu Bello University Teaching Hospital Zaria. It is my pleasure to request the chair to anchor this session. Thank you.
My name is immediate past president of the I'll have my
Thank you, Prof. I will quickly invite the presenters up here. Can we have Stephen C. Igbiankama? Is he around? Please come up. You are going to speak on ICW 048. That's your abstract number. I believe you all have the programs with you. Anyway, you introduce your text when it's your turn. The next speaker is Akin Kunle Abimbola. Akinkuade Abimbola, not available, and you have two papers to the name here. Akinkuade Abimbola. You are presenting two papers. Please take your seat. Obiora May. Abstract ICW 016. We've taken already ICW 021. Last but not the least, Samson Igbiankama again. You have another paper here, ICW 020. So without wasting much time, because of time constraint, I think we start now.
So, we don't have that much time. Your presentation is 7 minutes, and then we have 3 minutes for questions and answers. So I'll call the first presenter, with Samson Yabia, and he's going to tell us about the title of his presentation, Association Between Social Demographic Factors of Hepatitis B, risk factors, and hepatocellular carcinoma, a final stage. Sorry, yeah. So the title of his presentation is Association Between Social Demographic Factors, Hepatitis B virus risk, and hepatocellular cancer.
Thank you very much. Slide please. So I have a co-presenter who is also mine. All right, thank you. Yes, sir. So my name is Samson Chinomso Igbiankama. I'm presenting on this topic, and here is my co-presenter and co-author, Dr. Sunday.
Thank you so much. Yeah, so we'll try to look at the social demographic association between hepatitis B virus and then liver cancer. And we took a different dimension in this approach because the topic is actually to choke liver cancer, but we know we can't do much when the patient already presents with metastasis and then all the cost of radiotherapy and all. So we took some step backward by asking, are there some social demographic factors that are linked to liver cancer and how can we prevent them? So in asking that question, some of the things we'll find out is that topmost, hepatitis B virus is highly associated with liver cancer. In fact, over 80% of our liver cancer patients have hepatitis B virus. And then we continue to lose a large number of people. As of 2022, Nigeria lost about 4,000 people to liver cancer. So just to remind us of the sad realities, over 300 million people are living with hepatitis B globally. That's as of 2019. In 2022, there were over 250 million, which is still another large number. And then hepatitis B virus, especially the chronic part, proceeds to liver cancer and then cirrhosis. Now, and despite all we know about this, many cases remain undiagnosed, and even after diagnosis, the prognosis is poor due to poor presentation, due to late presentation and metastasis. So our study aimed to look at, as I said, the social demographic characteristics associated with hepatitis B, the knowledge and risk behavior, and whether this positively or negatively impacts outcome with the liver cancer. Some of the research questions included, what are the social demographic factors associated with hepatitis B, and is the knowledge associated with risk factor? That is, if people know better, do they tend to avoid some of this risk factor, or does it affect it in any way? Okay, our method was during the last Cancer Day, Cancer Week in February. The participant was 320. It was a descriptive cross-sectional study, and ethical approval was gotten from National Hospital Ethical Review Board. And these are some of the demography. Over 70%, 224 of our participants were female, while 30 were male. And over half of the participants were single, widow, or separated. And then the age range was between 18 to 64. And these were other characteristics regarding the religion. Then, in terms of the education level, we had over 86.9% reporting higher education, and then 42 participants reporting secondary education or lower. But this is actually a pilot study which we hope to scale up to rural areas where the educational level might not be as high as this. Okay, some of the measures we looked at were knowledge of the hepatitis B virus. We scaled it from 0 to 8, then risk behavior scale, and then their current health, and then also the scale on demographic. My colleague will continue from this. Thank you.
Thank you very much. For our data analysis, we analyzed our data using the statistical analysis software version 9.4, and we employed the multinomial logistic regression. And for our scales, the knowledge scale had two questions from 1 to 17, which were categorized into high knowledge, medium knowledge, and low knowledge. Then for our risk behavior scale, there were 8 items on the scale, which was also categorized into high risk behavior, moderate risk behavior, and 0 or low risk behavior. Our results showed that for demographic, females were more likely than males to have medium knowledge of hepatitis, of hepatitis B or hepatitis. Then with single, widowed, and those who were separated had higher odds of having medium knowledge of hepatitis. Then for those who had lower educational level, they had lower knowledge of hepatitis compared to those who had higher educational level. Then for occupation, those in professional managerial positions, civil servants, had medium knowledge of hepatitis compared to those who were unemployed and labor workers. Our results with regards to risk of hepatitis showed that
those with lower levels of knowledge of hepatitis B were more likely correlated, were more likely to engage in high-risk behavior for hepatitis B. Our conclusion is that to win the war against hepatocellular carcinoma, we need interventions that are targeted to these social demographic factors that have been shown to impact hepatitis B. Thank you very much.
Well done. The next presenter has abstract. I think available for Dr. Abimbola Akinkwade. Please, can you tell us where you are, where you're coming from, your university or your center? Thank you. Sorry, the title of her presentation is Outcome of Colposcopy Examination by Trainee Colposcopists in Basic Training Course. Is that right?
Yes. Good morning, everyone. I'll be standing on the already existing protocol. My name is Dr. Akinkwade Abimbola. I'm a consultant gynecologist from Department of Obstetrics and Gynecology, Gariki Hospital, Abuja, Nigeria. I'm presenting here on behalf of NSCCP, that's Nigerian Society for Colposcopy and Cervical Pathology, and these are my co-authors. The title of my presentation is Outcome of Colposcopy Examinations by Trainee Colposcopists at Basic Training Course. Colposcopy is a vital triaging procedure for women screened positive for pre-malignant cervical disease. In Nigeria, the limited number of trained colposcopists poses a challenge given the high burden of the disease. In response, the Nigeria Society for Colposcopy and Cervical Pathology, NSCCP, initiated an intensive training program for healthcare providers nationwide. And the aim of the study is to describe outcome of colposcopic examination carried out by trainees. The objective is to determine the prevalence of normal colposcopy findings, to determine the prevalence of abnormal colposcopy findings, to determine the accuracy of trainee clinical colposcopy findings using trainers' findings as standard, to determine the accuracy of trainee clinical colposcopy findings using histology findings as standard. There were 50 participant trainees that were evaluated. The trainees had hand-on colposcopic experience procedure on 63 volunteer women under the supervision of each of the trainers. The result sheets of the colposcopy examinations conducted by the trainees were collated. We matched the colposcopy diagnosis with the histology report if biopsy was taken. Where biopsy was not taken, we reported the colposcopy diagnosis of the trainee evaluator as corroborated by the trainer. And the result shows that total hands-on colposcopy were 63, of which 73% had normal colposcopy findings. Accuracy between trainee and trainers was 90%. 5% had low-grade lesions, 3.2% had high-grade lesions, 3.2% had inflammatory lesions, and 15.6% were unsatisfactory. 9 samples were sent for histology, of which 1 showed condyloma acuminata, CIN1, 1 was inadequate. See and treat were done on 2. The accuracy between histological and clinical colposcopy was 77, And this is the prevalence of normal and abnormal colposcopy. We realize that accuracy of 90% here. And here, these are the colposcopy findings that we saw during the clinical colposcopy. And these are the histological results. Then histological results corroborated with the clinical results showed an accuracy of 77%. So in conclusion, training skills were considered satisfactory, and we recommend more sections of colposcopy training to be organized all over the country. Since training learn fast, more sections will increase number of hands-on practitioners, and we solve the problem of patients being lost to follow-up or being overtreated. This will have a role to play in the cervical cancer elimination target. Thank you.
Well done, you kept the time. But if you want to continue, just have a wait and then go to this. For your want to continue. Okay. So, our next presentation is still on colposcopy. A profile of attendees at a basic colposcopy training course in Abuja, Nigeria.
Thank you very much. I've already introduced myself, and these are my co-authors. And the title of this presentation is Profile of Attendees at a Basic Colposcopy Training Course in Abuja. I'm also representing Nigerian Society for Colposcopy and Cervical Pathology. Colposcopy is vital in the investigation of women screen positive during cervical screening program. Like we said yesterday during the presentation, without colposcopy, we may overtreat, we may undertreat, the patient may be anxious, and there may be risk of financial burden to the patient. So colposcopy is very vital. A 4-day intensive basic colposcopy training program was conducted by the Nigerian Society for Colposcopy and Cervical Pathology at the National Hospital, Abuja, aimed at capacity building of colposcopy workforce. Now we have patients that have cervical cancer, patients that have pre-malignant lesions. We have hospitals. In these hospitals, they need colposcopy, but there is no colposcopy. So that is the essence of this presentation. 51 participants had didactic lectures on colposcopy, starting from the physiology, anatomy, everything, even genomics about HPV DNA and cervical cancer. After which reagent preparation was done. They were taught how to prepare 3 to 5% acetic acid, freshly prepared one. They were taught how to prepare glucose iodine solution from the iodine crystals. And they were also taught the different colposcopy models, starting from the binocular to monocular to the digital, and how to operate them. Then also they were taught on the loop electrosurgical excision procedure, LEAP, and how to use them on models. They were taught thermocoagulation simulation for see and treat procedures. So the objective to determine the demographic profile and medical field experience of attendees at the training course, to evaluate the trainees' experience at colposcopies, to evaluate participants' access to different colposcopic equipment. So the result shows that there were a total number of 51 participants, and we realized that 2 people were interested in cervical cancer. They came from their different offices. There were 2 civil servants, 45 medical doctors, and 3 nurses. They were colposcopy nurses. That means we need more colposcopy nurses, and 1 student that is interested in cervical cancer or had experience in cervical cancer. 51% had more than 10 years experience. That means they are not young doctors or they don't have experience at colposcopy. 83% had observed colposcopy being done prior to the training, but they have not done it by themselves. 66% had performed colposcopy, of which only 2 had a formal training, performing a colposcopy training. 22% had no colposcopies in their centers, Of those that have colposcopy in their centers, 55% have binocular. The rest have different other types. Then, see their job description, we realized 45 doctors, nurses were just 3. So we need more nurses. There were more women than men. Women are more interested in cervical cancer. Then, out of the 36 states, we were able to get participants from 23. So of which FCT carried the highest percentage, 10 came from FCT. So also, people that have had 10 years, more than 10 years experience, they were 26 in numbers. Okay. So those people that have observed colposcopy, 43. The rest, 8, they have not observed it before. Then those people that are performing 34. Those people, the different colposcopy in the people that have colposcopy in their centers, yes, 40. Then the different colposcopy, binocular, 22. Monocular, 12. Conclusion, colposcopies are available in 4/5 of participant centers. 2% of the participants had formal training. So the recommendation is that we have noticed gap in the training and in the acquisition of colposcopy. Note that we are trying to eliminate cervical cancer by 2030, and we are working as doctors or medical practitioners in an institution where we see people with pre-malignant lesions. But by the time you diagnose pre-malignant lesions, there is no treatment for it. You just jump colposcopy. What will be the fate of the patient to come with advanced stage cervical cancer? So these are the gaps. So this gap among medical practitioners in cervical cancer diagnosis and treatment may help in policy making as regard training practitioners on colposcopy and equipping hospitals. If all the facilities are equipped and all participants have formal training, not only thinking of what you have seen and making a wrong diagnosis, perhaps may help in cervical cancer elimination targets. Thank you for listening.
Thank you very much, and we kept it count. Presentation. Well done. The next presenter is abstract. Sorry, yeah, abstract. Yeah, ICW 016, and she is Fiora Lee, and she's going to her presentation is assessment of psychosocial burdens of cancer survivors that attend oncology clinic in UNTH, Ituku Ozara. Thank you.
Good morning, everybody. Standing on the already existing protocol. This slide, please. Assessment of psychosocial burdens of cancer survivors that attend oncology clinic in University of Nigeria Teaching Hospital, Ituku Ozara, Enugu, by Obiora May Oloma, MS. As you can agree with me, there are so many advances in cancer treatments, and this has significantly increased the number of long-term cancer survivors, leading to a growing focus on their psychological burdens after treatment. We tend to neglect such when we finish with the treatment of these patients and we no longer ask after their welfare. So survivors, they face a lot of problems ranging from emotional, psychosocial, psychological, financial, that persist long after of their ailments. And you find out that not only these problems do they face, when they are faced with these problems, they now start looking for the coping strategies. And you find out in these coping strategies, it is